So the first question is, what's minimal residual disease? And the next one is, why do we need to measure it? We're going to refer to minimal residual disease as MRD. And it's becoming increasingly important because, as you've heard, we have all sorts of combination regimens, including ones with antibodies now, being used in frontline therapy that induce responses in about 100% of patients. And we heard from Dr. Wiesel that in the transplant, the depth of response is critically important in terms of predicting outcome. And the same is almost certainly going to be true for non-transplant therapies in patients who never get transplant, or in patients who are getting first or second line therapy who attain a remission. How do you compare regimens that seem to work in everybody? And one of the most important ways is not just to see how many patients respond, but how long do those responses last? And we already saw that MRD negativity predicts that longer duration of response. The picture on this slide is a picture of an iceberg, and it illustrates one of the sort of the fallacies of our response criteria in myeloma. You can see the boat coming in, the SS patient coming in towards the iceberg, and if we think about the iceberg, that big mass of ice, as the tumor burden that the patient's coming up against, right? The part you can see is the part we measure in blood tests, right? And the problem is there's a lot underneath there, and we know from history that that can also be a problem. So think about complete response using just blood tests and urine tests as skimming the top of the iceberg off the top, down to just under the surface of the water, and then not checking out whether or not there's anything left under there, right? That's what MRD testing does. When you get to a complete response, you've gotten rid of 99.9% of the cells perhaps, but there's more in there. And we are going for way, way deeper suppression of the myeloma when we talk about MRD. We're talking about taking billions or trillions of cells and getting them down to hundreds or thousands of cells to become MRD negative. And of course, if we want to cure somebody, we actually have to get them to 0 cells, we think. So MRD is the presence of small amounts of residual myeloma cells left after treatment. And MRD testing should be able to detect at the least 1 in 100,000 cells or better. And the most sensitive assays that we're using right now look for 1 cell in a million. MRD positive means that the test you're using to look for this small residual disease is still detected, and MRD negative means that we are not detecting those cells. And the level of detection can be different depending on the methodology. Dr. Wiesel touched on this. We talked about flow cytometry, which uses basically antibody-type therapy technology to analyze the markers on myeloma cells. And we use something called multi-parameter flow, meaning you're looking for sort of the right combination of markers on the surface of the cell to pick that cell out as the myeloma cell, compared to other cells in the marrow that may have one of those markers but not all of them, or none of those markers. And then we have sequencing, or next-generation sequencing, which looks at unique genetic sequences that are in the myeloma cell that characterize it. And this is actually the more sensitive approach until recently. Now there are increasingly sensitive flow techniques, but generally the flow technique looks for 1 in 100,000, 1 in 10,000 to 1 in 100,000 cells. And the sequencing technique looks for about 1 in a million. So it's more sensitive. Flow cytometry is available pretty much at any lab, but it's not standardized. There are commercial sequencing types of MRD available. It's not done individually at any hospital lab, or even at specialty university centers with big myeloma programs. Next-gen sequencing is often not done, but commercially this is actually available, but it's not yet widely in use. I think we already sort of heard about why we care about achieving minimal residual disease negativity. We learned that from the trial that we already saw. I'm not going to belabor this, but there was a randomized trial that compared RVD with or without early transplant, and we already heard that more patients were MRD negative in the arm that included stem cell transplant. In this study done in France, maintenance therapy wasn't forever. Maintenance therapy was for a year, and at the tail end of this therapy, whether you got transplant or not, after a year of maintenance therapy, MRD testing was done. And what we see is using, in this case, this is the graph for the patients that they did sequencing, next-gen sequencing on. You could see that the patients who were MRD negative fared better. This is a graph that shows progression. And remember, the top line is the patients who are progressing less slowly. And the top line shows patients who had less than 1 in a million myeloma cells left in their marrow at the end of therapy. And this is measuring patients who are not getting more therapy. This is freedom from progression after you've stopped therapy. You can see that there is a major difference in these groups, including a real group of patients who a year or more after stopping therapy are still doing fine without evidence of progression because they had extremely deep response during the time of their therapy. Now, the sensitivity question that we came to, I want to help people understand this. So I want to use the iceberg analysis again. And so we have 5 patients all starting with the same disease burden. Patients 1, 2, 3, 4, and 5. We treat them with RVD. We give them transplant. And all of them have a complete response because there's not one iceberg left above the water. Right? So using blood tests, you've said you're all in a complete response. Okay? But you can see from this picture, if we had a way to actually visualize the burden, right, you obviously can look at this and say, well, some of these people had a lot more of a complete response than others. So if we use a test that, say, the intermediate sensitivity MRD testing, right, you've sort of weeded out the 2 patients who had the least good response. You still have 3 patients that are MRD negative here, right? So this is the crux of why sensitivity matters. Because if you had a more sensitive test, you'd actually be able to find the 2 who had the very best response. And it turns out that these 2 patients actually had better outcome than the other patients. The patient number 2, even though they were MRD negative using the intermediate sensitivity technique, they weren't as negative. They weren't as deeply suppressed as the other 2 patients. And that patient actually does a lot more like the other 2 patients than the ones who have the deeper response. Does that make sense? So the sensitivity of the test doesn't determine how the patient responded. The sensitivity of the test helps you truthfully, accurately find out how the patient responded. Okay? So when we say someone's MRD negative and we expect to sort of reap the benefits of that MRD negative status, you look as hard as you possibly can for that residual myeloma. Right? Makes sense. Okay. And this is an example of a graph that, different groups have looked at this. The French have looked at this, the Spanish have looked at this, and they look at, using different cutoffs. How is the rate of progression using different cutoffs? And what you can see here is that the harder you look, the deeper the sensitivity of the test, the more likely you are to identify patients who really are going to have long freedom from progression. Okay, so we want the most sensitive test possible. The key points from the studies analyzed is that being MRD negative is correlated with longer progression-free and overall survival. But again, you saw that some patients, even the MRD negative patients, sometimes relapse. So it does not necessarily mean the same thing as cure. In fact, we don't know if it ever means the same thing as cure, but we are going to find out over time. And MRD negativity may be more important in patients with high-risk disease. Okay, because those are the patients who are more likely to have early progression. And it may be more important to really eradicate those misbehaving clones. Limitations right now, we're doing it on bone marrow still. Blood tests are going to be developed and would be far more convenient. And it is also quite clear that there are pockets of disease that are outside of the bone marrow that are not necessarily picked up by bone marrow sampling for MRD. So for instance, if you had a soft tissue mass that might best be found with something like a PET scan. And I think a lot of people are thinking that true MRD negative status may ultimately require both a bone marrow or some other sort of tissue like blood sampling plus imaging to rule out residual disease. So final thoughts, MRD testing in practice, not quite ready for prime time because we have questions to sort out. It will help us figure out what the best regimens are in the future. We think that MRD negative status correlates with improved outcomes in both transplanted and non-transplant patients. It's not standardized yet. We have not finalized flow versus sequencing. We're still trying to figure out the optimal sensitivity of the test and the best time to do the testing. We don't have the answers to certain questions like this. Can you take an MRD negative patient and stop therapy safely? Should MRD positive patients who have otherwise meet all criteria for good response, should they switch therapy just to try to reach MRD negativity? And if a patient converts from MRD negative to MRD positive but is otherwise doing okay, should you switch or restart therapy? We don't know the answer to any of these questions, but these are the important questions that we're going to be studying as our therapies get better and better at pushing patients to this status. So with that, I'm wrapping up. And let's invite everybody else up here. We're going to start this in a sort of panel-style discussion. And do we have questions? So maybe you can.
Is the bone marrow biopsy a more accurate way of MRD testing?
I think as Dr. Zonder just did beautifully, you start with the simplest stuff, blood, like SPEP, IFE, that was covered. Then you ideally incorporate imaging, and then you get to the marrow. As has been pointed out, that if somebody has, and we know that there's some patients who tend to have just macrofocal myeloma. Their myeloma shows up in spots on the PET scan, but is not readily measured by a blood test or urine test. So if that patient were to have a marrow that was MRD negative, it may not tell the complete story as much as the imaging would. But for the typical patient, I think the idea is that you can do this marrow. The only caveat I would put is I think, it'd be, as I heard the analogy, the hemoglobin, which we all measure on a CBC, if you take a patient's blood specimen and run it across each of our institutions, you're going to get a pretty comparable number. With the MRD testing, that may not be the case. You take that same aspirate from that patient, and you could even take it from two different sides and in the same patient, and you send it to all of our institutions, depending on how quickly it gets to our institution, what exact technology is used, how well it's analyzed, you may get very different results. And that's, I think, why we need a little bit more standardization. But if that is done, this would really be a game changer, particularly for the newly diagnosed early phase.
And another question, should I ask my doctor to get MRD testing after transplant?
After transplant, so to even think about MRD, all the blood and urine tests have to be negative first. So if you achieve that, which is probably over 50% of the patients, then it may be reasonable to look for MRD testing. But again, as it's been mentioned a couple times, there's no standard test. It's not done in all institutions. This is not something you just walk in and say, I'm ready for my MRD today. It doesn't happen that way. The other thing you have to realize, that which my colleagues know that this happens, is some of the patients get MRD testing when they still have proteins. Their MRD is negative, but they still have definite evidence of abnormal proteins on their blood tests, which means you missed where you took the bone marrow, because that bone marrow, the reason it's called multiple myeloma is back in the 1880s, the guy who actually originally called it multiple myeloma found it was in patchy places. So when you take a bone marrow and it comes out negative, it doesn't mean that that's your whole body. So in the absence of negative blood and urine tests, it certainly probably shouldn't be done. And not only that, if you have PET CT or MRI findings that remain positive, it's probably not doing you any good to get the MRD testing. Save yourself a bone marrow.
And this is a great question, just popped up a few seconds ago. Is MRD testing only done in the clinical trial setting? And I would say, are there clinical trials looking at MRD right now?
Yeah, so almost, right, every upfront trial now that has a regimen comparable to or better or projected to be better than RVD is absolutely looking at MRD testing. It's probably going to be a key endpoint to try and distinguish between regimens in the future, but also it's part of the important work of trying to figure out sort of standard optimal technique for measuring MRD. It is going to be very difficult. I mean, depending on, we always say that it's not really kosher statistically to throw the results of 3 different studies up side by side and saying, look, this one has the best curves for a variety of reasons. But that's probably even more true for this endpoint of MRD testing, because if one uses flow and one uses sequencing with a different sensitivity and one uses flow that has a different panel identified, they're basically different. They're completely different tests. And you will not reach the same conclusions using 3 different technologies, across 3 different studies. So we really have a lot of work to do.
I was going to add too, I think this is an interesting development on the part of the FDA, because in not just myeloma, but all of oncology, because historically to get a regimen approved, you had to show that one arm improved overall survival. And that was the only thing they would accept, that people lived longer. That's reasonable if the prognosis is very poor, you can show that. But now, fortunately, in myeloma, patients are living so long. How are you going to do a reasonable study if the typical patient is living many, many years? You would never answer these questions. So I think for a while now, the FDA has accepted progression-free survival, which you've heard is just the duration of remission. But now we're getting to the point for newly diagnosed, and that's why I think it matters what disease you're talking about. There's a difference between newly diagnosed in maintenance settings versus relapsed and refractory. The more relapsed and refractory you go, the less you need MRD. The more you go up front, the more you need MRD, because those patients are going to have great outcomes. And if you're going to show in any kind of reasonable time frame that one regimen is better than the other, you need these novel technologies. It's almost like an arms race. As the treatments get better, you better have better diagnostic technology to keep up, and then so on and so forth.
Is MRD test? Oh, we already answered that one. MRD, how many cells out of or percent of the total cells is considered MRD?
So again, what?
You answered it.
I mean, you're talking about reducing it by 99.99 something, at least 4 decimal points after the 4 numbers after the decimal point. I'd rather, and maybe more, maybe 6. I mean, you're looking for extremely deep reduction.
I think it's really exciting that we're even talking about MRD. I mean, we've been using, the SPEP is, it's 70 years old, and the light chains are about 15 years old, and that was as new as things got in order to detect where the disease is. And of course, the urine test is 174 years old. And now we have a new technology that is telling us deeper levels of response than ever before. And we used to do these meetings, I guess, 2 years ago, and we didn't talk about MRD. And just in 2 years now, patients are talking about MRD, which is really exciting because it's moving the entire myeloma community forward into more molecular testing.
Maybe I'm curious, I'll throw a question out in the interest of asking what people, that when we teach medical students and you're talking about a test, given the false positive results, false negative results, the cost, the anxiety, when you do a test, you should be prepared to answer how are you changing the patient's management based on that result. So I'm curious, if we ask our colleagues, outside of a clinical trial, what are you doing differently with the MRD results?
I'll say nothing right now because we don't have enough data.
I think that's an excellent question, and I think that the data is just not there to tell us that we can use it to make decisions. So we are just monitoring it and not making any decisions based on it.
David, do you have any? anything with it?
Are you sure you want me to comment?
Yeah.
So if you really want to confuse everyone in the room, and you look at some of the data for MRD testing, so I showed a brief schema of a study, and Dr. Zonder showed the same schema in a little different picture format of transplant versus no transplant. And we both said that the people that did MRD negative did better than those that had the transplant. But what we didn't say is the people that are MRD negative without the transplant did just as well as those that with the transplant. And that makes things very confusing for everyone. So if you're MRD negative, you really didn't need the transplant. I hate to bite my own foot, but that's what the data showed. So MRD is actually a very powerful tool that we're still trying to understand what we should do with it.
So I saw confusion at the table based on this. So the reason why it's better, so being MRD negative means something very good no matter how you get there. The difference between the arms on that study was that way more patients achieved that endpoint with transplant. So it wasn't that you somehow improved, well, you know, it's the MRD negative patients did just fine. You just pushed more patients into that MRD negative range with the intensive therapy. That's why they did better. But the patients, you know, the patients who got there did fine in both arms. That is absolutely correct.
I think the one other point to make about MRDs, it's also, again, a time component, which is it's one thing to be MRD negative at one time point, but is it sustained? And that's another important point because, you know, I agree, I don't do anything with the MRD results with one possible exception, which is, again, not evidence-based, not prospectively validated. But if somebody has a low-risk myeloma and they're not tolerating therapy well, for whatever reason, they're having side effects, if they're MRD negative and it's sustained, we have a risk-benefit discussion with that patient. Do you want to do a trial of stopping therapy? Because I think and as Bart Barloghi has joined our institution, he's been doing total therapy for a while. There have been published about 10% of patients with myeloma don't relapse for more than 10 years. The question is, who are those patients and how do you identify them early on? And that we don't have good techniques for. But again, the best way to do this is really in a prospective study that you would take 1,000 patients, those who are MRD negative, half stop therapy, half continue. Those who are MRD positive, half intensify therapy, half don't. You would need to see that those kinds of studies read out. But again, that's going to be a long ways coming because first we have to standardize the technology before we then start making treatment decisions based on that.
We are going to get a hint at that, though, when the American counterpart study to the French trial that we both talked about. That French trial had finite maintenance therapy, and in the American half of that, or counterpart to that trial, it's essentially an identical trial up to that point, and then we do indefinite maintenance. And so what's going to happen is, in the American trial, we're going to have patients treated in a very defined way until maintenance, and then maintenance forever. And on the French side, you will have patients treated the same way who get maintenance for a year, and you will be able to compare what happens following that 1 year, at that 1 year time point, you know, in the patients who are MRD negative who stopped therapy on the French trial versus patients who are MRD negative or MRD positive who didn't stop therapy in the American trial. So I mean, we're gonna start to get that. It's years away, but not many years away. It's just a few years away, probably.
Okay, so those are great questions and answers. And then I'm going to talk about my hot topic is going to be precision medicine. And one thing, and who knows what precision medicine is? If you raise your hand, if it's absolutely crystal clear. So people from the MMRF, of course, know, and I'm sure our esteemed panel is very familiar with it. So hopefully I can explain some of that, because just as MRD is a molecular technology that is driving myeloma forward, so is precision medicine. So what is precision medicine? So there's the usual schema of how we treat patients is that we get patients and we give them a pill. So we take give everyone the same pill. And then one of three things are going to happen. Some patients are going to benefit, and in myeloma, using RVD, more and more patients are benefiting. There will be a few that won't benefit, and then there will be those that have adverse events. And so we should be able to do better than pulling something off the shelf to give everyone. And that's what precision medicine is aiming to do. So with precision medicine, what you do is that each patient benefits. What we do is that we do the DNA testing. So we need some way to figure out the differences between patients with myeloma. As you know, that everyone has a different story with myeloma. Their myeloma has behaved differently. And the way to uncover that is to do testing for the molecular mutations in myeloma. So you do a DNA test, and then for instance, if someone has translocation or the 11th and 14th chromosome is stuck together, you may receive one therapy. Sometimes the DNA tests will find a mutation in the RAS pathway, in the MEK pathway, and then some patients will have deletion 17p, and specifically the gene that is on 17p that is so important is p53, so loss of p53. So after you do the DNA testing, then you can tailor the therapy. Each patient gets the therapy that they need for their mutation. And so if you have the 11-14 translocation, you'll get a drug like Venetoclax, and I'll show you some data on that. If you have a MEK, in fact, that's a remarkable name for someone has a MEK mutation called mechanist. And then if patients have loss of p53, they can receive an MDM2, and that's also, and all these are either clinical trials that are coming up or clinical trials that are being performed right now. There was a presentation at the American Society of Hematology meeting from the MMRF that talked about the studies that we're doing with molecular medicine and with precision medicine. So in this study, we have at the University of Michigan, and everyone on this table is involved in this study. There's a gene profile that's done on myeloma cells called OncoSeq. And just like I mentioned earlier that the FISH study looks at about 14 different mutations, the OncoSeq looks at almost 2,000 different mutations in myeloma, including all actionable clinical, because over the decades we've learned more and more about the mutations that cause cancer, and it looks for all that, including genes of biological interest, the kinases, and gene expression. It looks for point mutations, and I can go on and on about all the little detailed things that make up an individual's myeloma. And then the data is then analyzed, and then a supercomputer reads the data and then spits out, I shouldn't say spits out, displays, or that's a good word, or yeah, I don't know, yeah, that's a good word, displays, the results within 10 days. And the mutation results are matched with clinical trials around the world or drugs that are approved for other indications, which I don't recommend going on other drugs for other indications, but for some people that may be their only option. So this is kind of how it works, that we isolate the plasma cells, we then get the bone marrow, isolate the plasma cells, we're able to do the DNA and sequencing studies, and then the supercomputer, which is not a laptop, it's a little bit more complicated than that, goes through the sequence analysis, and then a report comes out. And this is, I mean, this is in micro speak, but this is one of my patients' mutation analysis. And so the big things is that on one side is the mutations that he had. On the other side is the recommendation that was made by the supercomputer. It also gives links to clinical trials that this particular patient's mutations would match to. And it gives and also gives there it is. It also gives recommendations for outside clinical trials of potential drugs that would treat this particular mutation. And so in the study that was done by the MMRF and that we're all participating on, the early results that we got 192 patients with relapsed myeloma. They were again analyzed using the MyOncoSeq platform for about 2,000 different mutations. And actually 70% of the patients that had relapsed myeloma that we sequenced had actionable mutations. And some of those common mutations, and again, they have usually four-letter acronyms, and they're kind of complicated, but including 17p. But the really interesting thing is that there are drugs for all those mutations, and drugs either in development or have been approved for other types of cancer. And the one that we're going to concentrate on is BCL2, which happens in a few patients that have the 1114 translocation. So this is typical myeloma. That myeloma engages its cytokines which make the cell grow. It goes through all these different pathways that basically lead to BCL2. And what BCL2 does is it goes through the nucleus and the myeloma cell. It gives it a message that please don't die. BCL2 tells the cell continue to grow and proliferate and don't die, which defines cancer. If you happen to have the 1114 translocation in your myeloma, what happens is that those two chromosomes are stuck to each other. And when they're stuck to each other, what it does is amplify the BCL2 construct, which then amplifies the message to the plasma cell to don't die and continue to live. And if the myeloma cells, the cancer cells, don't die, they begin to pile up. And that's proliferation of the cancer. What if we could stop BCL2? What if the drug we could use could go in and stop the BCL2 in patients that we know have the 1114 translocation? We stop BCL2, then it stops the signal, the myeloma cells then disappear, and then the patient is, of course, happy because we got the mutation that they had, and then it took away it was able to control the disease. So I'll admit, full disclosure, that we had this trial at U of M. And when it started, I said, whoa, the response rate for patients on Venetoclax is only 21%. And I said, we can't afford it, and it doesn't have a good response rate. We're going to move on to something else. Then I kind of regretted that decision, because when you looked at just patients that had the 1114 translocation, it doubled the response rate, including patients that now are having CRs. And if you look at complete responses, those without the 1114 translocation, again, that is not precision medicine because they don't have the mutation. It was very low response rates. And if you, again, had that amplification of BCL2 that told the cells not to die, 88% response rate. That was a bad decision on my part because I didn't have the foresight to see, well, no one had the foresight originally, to see that the BCL2 patients were going to respond so well. And that's precision medicine, where in general patients don't respond as well, and a patient responding much better if they have that particular mutation. Again, there was no dexamethasone. So how many people like dexamethasone again? I thought so. So no dexamethasone in the study unless there were problems with the control over the disease. And it had only some minimal toxicities, some nausea and abdominal pain. And the big trouble with Venetoclax or other cancers is tumor lysis syndrome, where the cells all die quickly. And now there are multiple trials going on with using Venetoclax with other drugs, specifically in patients that have the 1114 translocation in BCL2. And again, it didn't matter how many prior therapies you had. If you had one therapy or 7 therapies, it worked regardless. So let's talk about another pathway. I mentioned the RAF and MET kinase pathway. So normally a plasma cell or even some myeloma cells will have a pathway where the cells, there's something that tells the cell to grow, a signal that goes on the green stalk, and then it goes through a pathway to tell the cells to grow. If you have a mutation of the BRAF or the MEK pathway, then you don't need anything to tell the cell to grow. The cell grows on its own and doesn't need any prompting for it, which sets the myeloma cells free of being dependent on any cytokines in the bone marrow. And there was a study that was done a couple years ago looking at patients that had the MEK mutation or the RAF/MEK kinase mutation. And just those patients, 51 were treated with these drugs, or the Mekinist drug. And here's a waterfall plot. And the way that the waterfall plot works is that if you're on the upside, your myeloma got worse, so the going up is worse. And if the protein went down, you're on the downside of the water plot curve, and it's better. And the number of patients that got better was impressive. And this was something that was done at, this was you guys, I think, at Memorial Sloan Kettering. And again, patients had decrease in their protein level. Worse, better, very impressive. So, but this is really early data, really early data. So would I go run to your myeloma doctor and say, I want to be put on Mekinist or these other drugs? We still need to do more clinical trials. And this was what Mary had mentioned earlier about the My Drug trial. And again, this is a study that's being done at all the MMRC institutions. And we do the molecular mutation testing that I had mentioned before. And if you don't have an actionable mutation, you get put on an antibody and ixazomib pomalidomide. If you do have an actionable mutation, again, about 76% of patients who come in, then they get their specific readout of their mutation, and then they get put on the drug specifically for that mutation. And if in 2 cycles they don't respond, then they get the same arm as the non-actionable patients, plus the precision medicine part. And we're really excited about the My Drug study coming out because it, again, is precision medicine for multiple myeloma. And as we discover new mutations, and we can replace one of the other arms of the trial with new drugs. But that, again, is under construction. And we do have some of these studies already going on for the RAS mutations, for the 17p deletion, the 414 mutation, the 1114. So all those are studies that are ongoing and are open or going to open very soon.
I think 2 of our speakers have to leave fairly soon because they have flights out, but I just wanted to ask a question of each of you. In terms of using this molecular information that we're getting about our patients, I think although the trials are listed as possibilities for these patients who need the information, practically speaking, there are often issues matching patients with trials. So how are you guys using this kind of data on your patients when you are getting the molecular profiling?
I think certainly we're using the 1114 data, and in a large part we're getting that we know that information from FISH testing and not relying on it. I think every once in a while we can't detect the standard mutation, and we can see evidence of 1114 on the genetic testing, and so, so that's that piece. The additional information that we get, I have become a little cautious with just starting treatment with drugs that are available without any clinical data in myeloma. One of the things I worry about is this concept of subclones. And if we see only a portion of the myeloma has this clone, and then we treat that, the concern I have, and maybe it's just a theoretical concern, but a concern I have is if I control that part of the myeloma, the other parts of the myeloma might get worse. And so I think the only time we've used it is in the patients who have the BRAF mutation and have seen, I would say, mixed success with that.
So we would like to practice precision medicine. A lot of the current actionable, what we call mutations, are not, there's no potentially actionable, there's no drugs approved. Some of the drugs that are approved for other diseases are very, very difficult to get for our patients with myeloma. The insurers won't pay for them. So you may have a MEK mutation where you want to give a Mekinist, the insurance company won't pay for it. And then we're no farther ahead than we were in the past. All of us participate in the same database with our patients. So again, it's 1,100 patients, but there's way more than 1,100 patients, and there's not really good ways to get this done outside of the patients already in the database. Our colleagues, we used to send some of our samples over to Mount Sinai, but because they actually would do the next generation sequencing for us. But it's hard to get the test done. Your local oncologist has no place to send it. If you're not in an academic center, it's really not a consideration. And even if you're an academic center, it's trying to get the drugs that may be applicable, getting them approved. So it's really, don't run out there right now and say, oh, I need to have my DNA sequenced so I can get the right drug. It's really not quite ready for prime time yet.
Yeah, I would agree that it's not ready for prime time, and that's why we're working on the clinical trial, and I think that's why the clinical trial is so important, is that it's done under controlled circumstances so that we each learn about, that all of us learn about how these drugs perform, because this is part of the deep space, regimens and clinical trials that we're doing, and we need to know more about clonal evolution when patients have really advanced disease, or they've had myeloma for a long time that's been active, that the myeloma can start to drift away from each other and they can start to behave very differently. So you can do a biopsy of one area and it may have a MEK mutation. Then you do a biopsy of the bone marrow and it may have a different mutation or lacks that mutation. So it's really important to be involved in clinical trials. And again, as all the speakers have mentioned, being involved in clinical trials pushes the disease forward. It is now more important than ever, as you've seen that some of the mutations only happen in 4% of patients. But if we get thousands of patients on a study, that 4% becomes a significant number, which can tell us significant data about myeloma. It's important for people of all ages, of all ethnicities, and all genders to be involved in clinical trials now more than ever, as we're using directed biologic agents. And if we don't have enough patients with the MEK mutation involved in clinical trials, then we're going to have to close that. And then we close the door on, we potentially could close the door on patients who really, really need that. So again, I would urge you, of any clinical trial, to be involved so we can push this disease forward and then out the window.
I think just to echo that comment, somebody actually asked during the break about if myeloma research translates into other diseases. Probably the best example of precision medicine that we have today in oncology is chronic myelogenous leukemia, CML, where there was a single gene mutation called BCR-ABL that they found. If you introduce that into a cell, you can create the disease. If you put that into a mouse model, you create the disease. You have a drug that blocks that gene, and you block the disease. And it's a single gene, single disease. This is not like that. This is myeloma, as we've said. It's because of multiple clones. And so even if you heard a little bit about smoldering and MGUS, but pretty much every genomic alteration you see in active myeloma is also seen in MGUS and smoldering. And it's neither necessary nor sufficient to become active myeloma, meaning you can have deletion 17p in MGUS, doesn't mean you have to treat that. You can have 414 in smoldering, doesn't mean you have to treat that. So it's not a simple one gene problem. And I think when we get into heavily pretreated patients, it gets even more complicated because there's numerous clones. And actually, we stopped because the lab, our colleague who was doing all the next-gen sequencing, it's very expensive, and his lab couldn't do it anymore. So now we've been doing it. This is something that is commercially available. If you get a marrow, you can have it sent to Foundation Medicine, so they do this as well. The Michigan study was also, I think, has met accrual very rapidly. But the problem with that is, again, it's multiple myeloma. So we've seen patients where the marrow will be completely normal, and then because they had a mass that was growing, we did paired sampling, and only the mass had that mutation. And so it doesn't mean, as Dr. Kaufman alluded to, if you just give that one drug, you're not doing anything for the rest of the disease. So I think the future of this precision medicine is not going to be monotherapy, but combination therapy. You're going to have to do something for the general myeloma and then add these additional agents to target those nasty, misbehaving clones so that you really stay on top of it. But I think, and even with Venetoclax we've seen, even though 1114 is great, there's also been a French study that showed that You saw the relatively modest response rate with single-agent venetoclax. When you combine it with Velcade and dexamethasone, you get very high response rates, regardless of 1114. So I think combination therapy is really, that's why you keep hearing it over and over. This is multiple myeloma, multiple clones. It can take multiple drugs.
Our last topic, Dr. Chari will be talking about clinical trials, and then after that we will have a faculty panel discussion where we go through some of the questions that have come through that aren't necessarily related to any one of the talks.
Okay, I think as you've all heard over the day, these trials are essential to make progress against myeloma. They help us develop treatment strategies to lengthen lives, improve remission duration, quality of life. And the way we do that, for example, you heard from Dr. Wiesel and Dr. Kaufman as well, the RVD with early versus delayed transplant. So we have a regimen, we have transplant, what's the right way to use them? And so that was a really important study that demonstrates that currently there's still a very important role for transplant. Also, you've heard about selinexor, you've heard about CAR-T, the bispecifics. These are all new medications that we still need. So we need trials to do both of these things. And also we need to understand the disease. So precision medicine, MRD, why do some patients have residual myeloma after transplant? What is in that clone? Can we then combine precision medicine with MRD? Can you take those residual cells, understand why that disease has not disappeared, and then go after that? So that's why this is really an important way of advancing our progress against myeloma. I really like this slide because it kind of gives you an idea of how complicated drug development is. You can't just go to the shelf and say, you know what, I'm going to take this drug and try it against myeloma. This is the process that typically you have to go through. First, on the very left is called preclinical testing. This has nothing to do with humans or even animals. It's just cell lines typically, where you're just looking to see, does a particular pathway, is it aberrantly upregulated in myeloma? Can you block it and cause cell death, but specific to the myeloma, not the entire system? And then you go from cells to animal models, and then you apply for what's called an investigational new drug approval from the FDA, and that's to allow you to proceed to human testing. That can take up to 4.4 years. Now we move into clinical trials. Phase 1, typically these are small, 20 patients approximately. You're just looking for what is the safe dose. There's no efficacy question because you can't ask how well a drug works till you know what the right dose is. So those are typically started at a very, very low dose, a fraction of what was tolerated in animal models. And then once that low dose is tolerated, you gradually increase the dose to hit the maximum tolerated dose. Once that's done, you can then move into the phase 2 testing, which is can be up to as many as 100 patients. And now you're really looking not only what is the side effect profile that was preliminarily seen, but how well does the drug work. And now if you see some promise, and this is what I was alluding to, typically in myeloma, there was a study that showed that if it's, as a single agent, a drug does not have at least a 20 to 30% response rate, likelihood of moving on for definitive approval is quite low. And that gets, but remember that gets harder and harder to do the more drugs we add. So there's a difference between thalidomide showing a 20 to 30% response rate back in the mid-2000s, and now in 2018 showing that response rate in heavily pretreated patients who've had all those new drugs that we've been talking about. So then you go, even if you have these accelerated approvals, like for selinexor, all the drugs recently, like carfilzomib, dara, pom, they all got these kind of accelerated approval because it was an unmet need. They all had that 20 to 30% response rate. The progression-free survival was around 3 to 4 months. So the FDA gave this approval because there was a patient need, but that's contingent on the definitive randomized phase 3 studies being done. And why do we need that? A good example of that is the checkpoint studies. So the checkpoint inhibitors in the initial phase 2 studies look very interesting. When you take patients who are refractory to Revlimid and Dex and added a checkpoint inhibitor like pembrolizumab, nivolumab, similarly with pomalidomide, there was actually a response rate of that 20 to 30%. So it seems like, wow, this looks promising, especially when these drugs are approved for almost every other solid tumor that we know of. But then when it got to phase 3 testing and you took 2 drugs versus 3 drugs, it turns out it wasn't that straightforward, and actually there was more side effects with the addition of that drug. It's a complicated story. It may have to do with how side effects are managed and detected, but the point is that is not a phase 3 study that led to approval, even though there was a promising signal. So this is why we have to go through these systematic movements towards approval. And then eventually the FDA will give this new drug application, and that based on the phase 3 data, and it leads to approval. And you can see that this entire thing can take up to 14 years. Usually that's a little compressed for oncology patients because the need is much higher than, say, for cardiology or GI drug. But that still, it highlights why we need to work collaboratively, because this process will not move forward without everybody participating. And with that slide, it's really even more impressive how quickly myeloma patients have been living longer, and how, to have 10 drugs approved since 2003 with that kind of a framework is really impressive. And we've gone through all of those drugs, so I'm not going to list them. And we have numerous new drugs, and really to get to personalized medicine, I think our lymphoma colleagues have done a much better job of personalizing medicine. So when we say non-Hodgkin's lymphoma, it's not just one disease. It's actually so-called indolent lymphomas, moderately aggressive, highly aggressive. Each of those categories is treated differently. In myeloma, we can say low risk, high risk, but we don't yet really change our treatments based on that. And part of it is because, unlike lymphoma, where the pathologist can look under the microscope and say, yeah, this is an aggressive lymphoma, this is a low indolent lymphoma, you can't just tell that by looking at a myeloma cell under the microscope. And you really need to integrate the genomics and also how long the remissions are. And when we speak at ex-US, where they don't even have necessarily good FISH testing, the way you know that a patient is high risk is how long was that remission. If the remission is short, it doesn't really even matter what that FISH said, because that's functionally high risk. And so in many parts of the world where resources are very constrained, you don't do all the fancy testing. You just have to go by how the patient's doing. So, but to make progress, we really need to continue to do these. So here's some examples of patient questions that we have now. Should patients with smoldering myeloma be treated? I was kind of polling my colleagues. I'm curious we can even take this up. But there's these new SLIM criteria for myeloma that are not just CRAB, which is calcium, renal, anemia, and bone, but the SLIM criteria are basically laboratory tests. And should we be treating people for those tests? What is the best treatment for newly diagnosed? So you've heard that triplet therapy is good, but what about quadruplet therapy? Should this addition of CD38, will that be better than VRD? So DARA, VRD, will that be better than VRD? We have to see the data. What are the best drugs and combinations for relapse disease? So you heard about selinexor. Single agent's response rate might be to 20 to 30%, but the combination strategies are looking very promising, and it's being combined with multiple drugs. How can treatments be matched to patient subtypes and genomics, which I just alluded to, like our lymphoma colleagues? But studies can help us answer all of these questions. And so the things to consider: talk to your doctor about your eligibility, meet with the research nurse to learn more. Nurses are tremendous resources for getting information in a patient-friendly format. That informed consent, it's both the bane of our existence, but also the essence of our existence. These consent forms are often 20 to 30 pages. And I can tell you I've sat on these institutional review boards for about 15 years now. And so what we do in these meetings is we review all these consent forms. Obviously, not if you're the PI of a study, you're not reviewing your own, but you're reviewing all of your colleagues' consent forms. What we're doing there is, first, is the consent form legible? Is it understandable to a layperson? Does it accurately reflect the risks and benefits of the study treatment? Is it, and is it, at the end of the day, is this an appropriate reflection of what participation in that study does? And it's a lot to go through. And as I let, those TV commercials that list off all of those side effects, that is actually what's put on the ICF, these informed consent forms, but it's for your safety. And it doesn't mean that when you have this 30-page document that every single adverse event or side effect is going to occur, but it's important to be aware of, especially when you're dealing with a phase 1 agent where we don't even know the safety profile. We can say what might be expected from animal models. If we don't put all of that there, we're not doing our job. And so it's important that when patients sign consent forms, at our institution, we don't allow any patient to sign a consent form on the day that they're given the consent form, especially for a therapeutic study. So if we're asking you to do a clinical trial, you are asked, even if you say, I'm ready to sign, you're not, we say you have to go home and read this, share it with your loved ones. For those who speak non-English, it's required that they be able to at least read it in their native language. And if not, there's other ways of doing that. But I think this is why this consent form is important. And if you're asked to do something later in the study that's not on the consent form, you really can challenge that if you're asked to come in extra. Now, remember, though, that myeloma is challenging because it may say that this study you're going to come in once a week. That's fine for the typical patient. But if you as an individual have very low blood counts that requires more frequent monitoring, we have to do what's clinically appropriate and not just say, I'm going to see you once a week because the study said so. So there's this balance of what's required and what's appropriate for that particular patient. So the benefits of studies, typically these are standard of care. I know some of the questions that came up were cost related. The way clinical trials work is every clinical trial has what's called a schedule of events. So when are the different things that are happening? Labs, imaging, marrows, and that is then converted to a separate grid for the billing people, and what they do is they look at that and say, okay, which of these visits are standard of care? Typically, as you know, myeloma labs are typically done once a month, and then imaging is a certain annual. So anything that fits that would be billed to insurance because that's considered part of standard myeloma therapy. If then they're asking you for extra bone marrows, extra imaging, that is considered research, and then that would have to be covered. So that's how this is being done. And typically, the copays and all of that stuff that patients are it's really important. It's hard to get that granular answer because it really depends on each visit, whether it's standard of care or research. As I alluded to, you can have additional care and investigation as part of the studies. We all have coordinators, research coordinators, nurses. I actually think that if you're a research patient, you get a lot more attention than you do as a standard of care patient because there's a research coordinator, a research nurse, and research NP, and there's the physician oversight and then the clinical trial oversight. So there's a lot of hands on deck, and it's to really give optimal outcomes. So how do you go about finding a clinical trial? Ask your treating physician, check with the local academic center. The NCI keeps an active list. The MMRF, part of the reason all of these drugs have been developed is because we've all been working collaboratively with the MMRC to bring all of these new drugs quickly because for uncommon cancer, to get that many drugs approved, it really takes everybody working together. And that includes, first and foremost, patient caregivers, but academic institutions, nonprofits, pharmaceutical companies, the FDA, the academic institutions. Without all of these components, this would not really be feasible. And just to give you an idea of what's looking exciting, there's new oral proteasome inhibitors that are under investigation, next generation IMiD, so beyond Revlimid and pomalidomide, HDAC inhibitors, a lot of small molecules blocking those signaling pathways, more monoclonal antibodies which you've heard about. We've talked about Venetoclax, selinexor, and then lots of immunotherapies that Dr. Zonder did a great job. And then still more drugs, both small molecules and monoclonal antibodies that we can go over if people have questions. And so to summarize, the drive of research is really what's gotten us to this really robust table, but we need more. We don't expect anybody to be a guinea pig. It's important to say in oncology, people are not going to be randomized to placebo if there's not a reason to do so. So it's unethical to take somebody with active myeloma and give them placebo. What you might see, though, is like 2 drugs versus 3 drugs because you don't know if that 3rd drug is going to add to the safety and efficacy. But it would be unethical. And another time you might see that is in maintenance setting where no maintenance versus maintenance. But it's never going to be treatment versus no treatment for somebody who needs therapy because none of the committees that are reviewing these protocols would allow that to go. But at the end of the day, research is very tightly supervised and standardized, and as with the entire day of our talk, especially in research, it's important you communicate because that weird rash or that weird hearing thing that you heard might actually be a new side effect of the drug that we need to know about. And if more patients are reporting that independently, it's going to give us that information. So it's a great example of importance of communication. So with that, I'll stop and hand it back to you guys. Thank you.
There was a question earlier and about insurance programs covering clinical trials. And one thing about that is that in 20 states, United States, the insurance companies by law have to cover clinical trials. In basically everyone who is now here, except for AJ, is that in Ohio, Michigan, and in New Jersey, there are agreements between the insurance companies and clinical trials to have those covered too. And so the likelihood, if you're in this room, unless you're from Alaska, that clinical trials will be covered by your insurance. But in Michigan, it can vary from insurance program to insurance program.
It's worth actually also saying the converse, which is sometimes if you try as a physician to give a particular combination, it may be declined by insurance because it's not an FDA-approved combination. But that same combination in a clinical trial will be covered because the investigational drug will be provided free of charge. So I think it can go both ways. Sometimes it's a great reason to even think about participating in a study. I can think of several examples recently where the combinations were declined in standard of care patients but covered in insurance.
And is there any particular time when patients should consider clinical trials? Does it have to be when the disease is refractory?
No. I mean, I think that, well-designed clinical trials are out there for all stages of myeloma. That's not true. That's not actually a true statement. I think there are gaps in our patient population where there are subsets of patients where there haven't been as many trials, patients with impaired kidney function, patients with plasma cell leukemia, patients with coexisting amyloidosis. I think there are myeloma subsets that don't readily have access to trials, but for a typical myeloma patient over the course of his or her illness, there isn't a one right time for a trial. There might be a good trial for newly diagnosed disease. There might be a trial for post-transplant consolidation or for transplant, for maintenance therapy, and then later in the course of the disease, when it's beginning more difficult to treat, there might be trials that make sense at that time as well.
To echo your point, we recently looked at there's been a wealth of great phase 3 studies that have been published in myeloma in really very high-impact journals like New England, Lancet, et cetera. When we looked at those studies and applied it to real-world patients and all the eligibility criteria, probably at best 50% of patients in real world would be eligible for the studies. And it's actually part of a larger discussion in the oncology field, which is that our clinical trials are cherry-picking patients so much that at the end of the day, the results you get are not generalizable back to the patients that we're actually treating, because you're having underrepresentation of older patients, which is a big deal in myeloma, because if the median age is 65 to 70, and the studies are accruing patients in their 40s and 50s, the profile of the drug is potentially very different. So we need to do a better job of actually making sure that studies are accruing patients that really live and breathe in the real world and not these really cherry-picked patients that are going to do great with everything. So I think it's a big issue for oncology, including myeloma.
Well, there was a study that was done for a sleeping medication, and that sleeping medication was studied primarily in men. The drug was approved by the FDA based on the response rate for men being able to sleep, so the drug was released. And soon after the drug being released, then they found women were getting in car accidents. And then why were women getting in car accidents is because the sleeping medication was metabolized different in them than in men. And so they went back and they found that in that study, again, very few women were involved. And that is kind of the point about being involved in clinical trials, is that way back in the day when we were using chemotherapy is basically the same in everybody. But now that we're using biologic agents, there are differences between men and women and people of ethnicity and old and young. So having everybody, having all oars in the water, and asking your doctor about, is there a clinical trial available to me? Or even better, looking up through one of the search engines. And there are lots of beautiful search engines that are really easy to find clinical trials. Looking them up, printing them out, and bringing them to your doctor, saying, how can I get access to this trial and to these new drugs? So are there, it's very interesting. Are there any studies investigating the reversal of neuropathy?
No. The best way to reverse neuropathy is not get exposed to the agents that cause it to begin with. So unlike my colleagues, I almost never use one of the standard drugs, which is Velcade, bortezomib, because it induces neuropathy. Even though it's reversible, even if you give it once a week sub-Q, it still causes neuropathy in a significant proportion of patients. So I actually opt for either the oral proteasome, ixazomib, Nimlaro, or the other IV proteasome, which is Kyprolis or carfilzomib, and I don't use Velcade at all.
Well, there was a non-myeloma specific study that was presented at the American Society of Clinical Oncology meeting in, I think, 2006. And so they got patients of that with many different cancers. So that's the caveat, is that there were different cancers. And they all had developed neuropathy due to their cancer treatment. And so they got all these people that had neuropathy. And they did a trial of one group. They said, you have neuropathy, go home, come back in 6 months, and we'll talk again. The other group they gave L-asparagine to, which is an amino acid supplement thought to help with neuropathy. The third group, they told them to exercise anything 5 days a week for a half hour. Mainly, most people walked. Some people use exercise bands, resistance bands, but they did something to move for a half hour a day, and most went to the mailbox, to be honest with you. And what they found is that in 3 months, no difference. In 6 months, no difference. In a year, the people who had exercised, their neuropathy scores went down. The people with, and again, this is all cancers, not just myeloma. And then after 2 years, by exercising, the patients, the other two groups, had no change in their neuropathy. Their pain was the same on their first day to 2 years later. The patients that exercised had significantly less neuropathy by having a regular exercise schedule. And now our symptom management team, their primary recommendation for treating neuropathy at the time it happens is medications, but ultimately they start an exercise program.
So let me ask, though, is that because they hurt elsewhere now because of all the exercise, or did their neuropathy get better?
That was exactly the question when it was presented, was, do I have to do aerobics? No. I don't even do aerobics. And with clinical trials, how many do clinical, I think this was answered earlier, but how many clinical trials, again, are crossed over to other diseases, from myeloma to other diseases?
That's right.
How many things that worked for myeloma were able to be applied to other diseases? So let me start with this one. So interesting, daratumumab, Darzalex, targets this particular protein on myeloma cells called CD38, which is expressed, it's not only expressed in myeloma, but it's expressed very minimally in other cells in the body. So that being said, it does modify the immune system, and they have all these beautiful pictures of all the different ways this antibody modifies the immune system. So, for example, with that particular antibody, they're actually testing it in acute leukemia, and now they're testing it in solid tumors because they think that the modification of the immune system will allow the other drugs they're giving with it to work better. So some of these drugs do have some potential crossover activities because they act not just necessarily right on the myeloma cell, but particularly immunotherapies can act through other pathways and affect other aspects of your immune system that still may help patients with other diseases.
I think probably the best, the IMiDs, proteasome inhibitors, and even the HDAC inhibitors are all used in other B-cell cancers, particularly lymphomas, CLL. So there's a bit of overlap, but that doesn't mean it's a one-to-one thing. There are certainly drugs that are only good for B-cell lymphomas that don't work in myeloma, and there are drugs that only work for myeloma. But there is a bit of crosstalk, and I think it's, again, where partnerships like this can help not only myeloma, but other associated diseases and related diseases. Selinexor is another one actually being studied across many malignancies, solid tumors and liquid tumors. Yeah.
And there was, if I can mention another study that was done, which answers a question, is about the new shingles vaccine that has come out. And I don't know if anyone has any opinions about the new shingles vaccine that was in a clinical trial for patients with blood disorders and in myeloma.
So the shingles vaccine, the old one, Zostavax, has not been approved because it's partially live vaccine. So any of you who had the old vaccine is partially live, and it's not recommended for people with blood cancers. The new one is attenuated. It's not partially live. It's called Shingrix. It's a two vaccines. It's supposed to be two vaccine shot. It's supposed to be given 2 to 4 months apart. It has been shown after transplant in myeloma patients reduces the risk of getting shingles by something like 70%. I'm actually encouraging it in all my patients. For those of you who've ever had shingles, I normally leave people on either acyclovir or Valtrex for their whole lives because you can get it again. But I'm planning on giving my patients who've had shingles, have them get their immunization if we can demonstrate they have titers, because that's always an issue with myeloma patients. Their immune systems don't always get immunized as well as people without myeloma. But if they have titers, then I'm going to stop their Valtrex and acyclovir.
And just a practical note, which is that if you're going to get it, it may be better to get through your primary, because our cancer center actually is having trouble giving it because it's, again, for especially myeloma patients, it's not on label. It's almost easier to say that you're over, I think, 60, and therefore your primary can give it to you and have less insurance barriers.
It should be covered. It's about, supposedly it's $300 for the series of 2. Your insurance companies should cover it, can't promise it. It is recommended by the CDC for people actually, I think, over the age of 50 now, not 60. Well, I think the old one was 60. I think this one's 50. So everyone in this room almost, except for these young people up here, probably should be getting their shingles vaccines. It's effective, it's safe, and it's in your best interest.
And are there any trials that family members of patients with myeloma can participate in?
So generally, patients with myeloma, if you look at most patients with myeloma don't have a family member related person with myeloma. But when you look at large population studies, if somebody has myeloma, there's about a 2 to 4-fold higher likelihood of having myeloma or related cancer or B-cell cancer. There are efforts being done by specific individuals. We have one at Sinai, a geneticist, another one is in Boston. But if there's a strong family history, to collect samples from, the important thing is to collect not only the patient, but obviously the uninvolved, so the healthy controls to try to identify what might be the genetic marker. There was one kind of interesting publication in an African-American family that did show a higher, there was an aberrancy in a particular phosphorylation gene. But for the most part, this is still very early in research efforts.
Can I suggest that we just open up the general topics of questions now and just field some general questions, and maybe we could, I don't know if you have access to the question list, but maybe we could pass this down so that we could just so between all of us select some questions that we want to talk about or things that interest us to chat about.
So how close, this is a great question, how close are we to a cure? Any respondents? So I think that the more science that we apply to myeloma, the more people in clinical trials, the closer we get to a cure. And what's kind of, and Dr. Chandri had mentioned this earlier, that there are patients right now that have survived 20, 10, 15 years already. And then they succumb to other things like lightning strikes, and some get bitten by sharks and things like that. And so those patients are essentially cured because they died of something else. Their myeloma wasn't in the way. And so there are some patients who we have cured already. The trick is to understand who has come up with a definition of cure that everyone agrees on. Because and I can't say I agree with the definition of cure is you die of something else first. Else everyone would go jumping in the ocean trying to get bitten by sharks. But to come up with the definition everybody agrees on, and then be able to figure out what are the types of myeloma, because we know everyone has a different myeloma, we can categorize those, and which are the patients who we can treat to cure some types of myeloma, very slowly kinetic types, If we can figure out those people by using a specific test, we can address them specifically, and other types we can work on. So there's a type of lymphoma called Hodgkin's lymphoma. Hodgkin's lymphoma, when it was grouped with all the other lymphomas, was lethal. When you separated Hodgkin's lymphoma from all the other lymphomas and then studied that in isolation, the survival and the cure rate for that lymphoma rose because it needed a specific therapy for that type of myeloma. We need to do that for myeloma in order to figure out the different types of myeloma and then cure them individually. That's my opinion.
I think another important consideration in this topic is, again, going back to disease biology. So, for example, we looked at recently about 250 patients who had smoldering myeloma that then went on to get active myeloma, and then we compared them to counterparts that did not have a known diagnosis of smoldering, which, again, we take that for what it's worth, because as we know from a different study that in most myeloma patients, if you were able to go back 8 years prior to their diagnosis, 80% of patients will have detectable myeloma proteins. So it's not necessarily that the diagnosis was missed, but if they were asymptomatic for 8 years, that's great. But I'm bringing up this smoldering myeloma issue because when you compare people with smoldering myeloma to those who did not, and everybody started treatment, the people with smoldering myeloma didn't get into as many CRs, so they didn't get into complete remission, but they lived longer. So I think what I'm getting at is that sometimes people may have different clones in their myeloma. They may have an MGUS smoldering clone, and then the myeloma clone that actually causes the crab symptoms. And sometimes that's one of the other limitations of MRD. Somebody may be MRD positive, but that may be the MGUS clone, and we don't need to keep chasing that into complete obscurity, because that may cause a lot of harm to that patient without really helping, when in fact we really need to just go after that clone that caused the myeloma problem. So it's yet another illustration of why these studies are so important, because if we don't understand the disease biology, just chasing MRD in and of itself may not help people live longer.
And so we have time for just one more question, and this question has come up about 4 times. Why is the loss of a sense of taste, is that related to any of the myeloma therapies?
So we have often seen, well, not often, a few times we've seen that Revlimid is linked to a decreased taste. We've also seen it linked to dexamethasone use. So often we will either hold the medication and see if the loss of taste resolves and completely goes away, and then we may restart it, or we might do dosage adjustments and decrease the dose of the medications to see if that helps. There's also been a few patients that as they've been on therapy, with time, the loss of taste actually improved, and you can use lozenges to kind of try to activate the salivary glands, and that may also be helpful in those circumstances. I don't know if anyone else has anything else to add.
I also have seen patients who lost the sense of smell, when especially some patients are in clinical trials where we have to report it, and they've lost the sense of smell again. We found out due to Revlimid, because as we stopped the drug, their sense of smell returns, and then we restarted at a lower dose, and they were able to keep that sense of smell.
I think the other thing, speaking to maybe what Ron, for instance, brought up earlier, is that it's not always, I mean, it may be other things that we're doing. For instance, a patient may develop thrush, which, causes a coating, a yeast coating in the mouth, which alters taste, certainly. I mean, you got to look, you got to do an examination, and it may not be a drug toxicity on taste buds, but maybe some other coexisting thing. And then the other thing, some antibiotics, Biaxin is sometimes added to dexamethasone-containing chemo regimens to augment the activity of the regimen. There's some literature about that, and certainly Biaxin, when it's added, can cause a metallic taste abnormality in the mouth. So there are definitely a number of causes, but I think in full agreement with you, Revlimid is the most common one by far.
So I think that's it. Thank you so much for coming out today.